Evening. My name is Tim Gibbs, Director and Principal Investigator for Delaware Health Force. Delaware Mini Medical School is a program of Delaware Health Force through the Delaware Academy of Medicine, Delaware Public Health Association. We are streaming live on YouTube. If you have any issues with connecting via Zoom, you can hop on over to YouTube. Nicole has put the link into the chat, and and you can watch that way. Just make sure to email Nicole and Sabine at delamed.org and let her know that's how you're participating. Just remember that this is a Zoom webinar, not a Zoom meeting. You can't see each other and we can't see you, the students. You can see us. We only use the Q&A feature, not the raised hand feature. So place any questions into the Q&A. Please don't ask questions of a personal nature. To the best of our ability, all questions will be addressed, some by staff, especially if they're of a housekeeping nature, others by the presenters at the end of the presentation. You do need to stay through the entire presentation, but once the Q&A starts, you can leave. As always, I remind that's when a lot of the good stuff comes out. So I encourage you to stay through the very end. At this point, I'd like to introduce Christy Handley, my colleague from the Sussex County Health Coalition, who will introduce this evening's moderator. Over to you, Christy.
Great, thank you, Tim. As you can see, Sussex County Health Coalition is a organization in Sussex County that is working collaboratively to make sure that our communities have a voice in the concerns and ideas that they have within their own communities. And we enjoy working with Tim and his group in this effort with the Mini Med School. Next slide. And I'm going to go ahead and I'm going to introduce Tabassum Salam. She is a board-certified internal medicine physician with 20 years of multifaceted experience in healthcare. In her current role as Chief Learning Officer at Christiana Care, she works with a multi-professional academic affairs team to deliver learning and professional development programs to physicians and other clinicians at all stages of their education. Dr. Salam received her medical degree from the University of Pennsylvania Perelman School of Medicine and her MBA from the Wharton School at the University of Pennsylvania. Thank you, Dr. Salam, for joining us, and I'm going to turn it over to you.
Thank you very much. Good evening, everybody. It is such a pleasure for me to be able to join many of my other Christiana Care colleagues as we bring a series of topics to this period of Delaware Mini Medical School. Today, we've got two of our best, Dr. Verma and Dr. Runyon. Dr. Devanshu Verma is one of our rheumatologists. He's also board certified in internal medicine. He graduated from Windsor University School of Medicine and completed his residency from Conemaugh Health System before he was a chief resident at Temple University. He joined Christiana Care in 2023 after completing rheumatology fellowship at Drexel and the University of Pennsylvania in Philadelphia. His interests include teaching and patient education, and he serves as the founding fellowship program director for Delaware's first adult rheumatology training program. Right here with us at Christiana Care, we look forward to welcoming our first fellows in 2026 in that program. He's going to be joined by our colleague, Amanda Runyon, PharmD. Dr. Runyon is a clinical pharmacist who supports the Christiana Care Rheumatology Clinic in her role through the Christiana Care Specialty Pharmacy. She assists patients with their specialty medications. That includes medication access and medication and disease state education and clinical monitoring support. She earned her PharmD from the University of North Carolina at Chapel Hill and completed her residency at Moses Cone Health System in North Carolina. I'm going to invite you both to take things away, and I know you're going to start off by telling our amazing audience all about your paths to your current stages in your career. So take it away, and thank you.
I hope everyone can see the screen and hear me okay. I wanted to first welcome everybody Appreciate everyone's time this evening. It's a pleasure to have people in the audience, some of who know me personally and some who have rotated with us in the rheumatology clinic at Christiana Care in both Newark and Wilmington. Today, this is a case of treat me right, but when rheumatoid arthritis refuses to remit. I'm excited to be working with Amanda in this. She's our excellent clinical pharmacist, and we're very delighted to have that exposure. Disclosures, there are none. We have no conflicts of interest. We're not reimbursed for the talk. Opinions are our own. And lastly, brand names are not sponsored. They're there only because some of you may be more familiar with the brand names than the generic ones. The goals first is for you to be familiar with how to become a rheumatologist and a pharmacist. Second is to understand how to address the common treatments for rheumatoid arthritis. And then lastly, understand how some of those treatments are actually administered. And you'd be surprised, even in traditional 4 years of medical school, we generally don't really are taught the logistics of how medications are actually brought to the patients. For example, we are all know about how to treat a certain disease, but rarely are we ever told how to actually get it for patients who don't have access, or how to actually go about the insurance processes, about how the different social support systems are available. So this will be a great introduction to that, which isn't taught in med school. I'll start off with the rheumatologist. Normally, I would ask a question of how many of you actually know what a rheumatologist is, but you can see that in your minds. And it is a physician. It is a provider, a physician, a doctor who specializes in autoimmune and inflammatory diseases. And that auto meaning self, immune meaning your immune system. The inflammatory is the key word. Most people will think of rheumatoid arthritis as the rheumatologist, and they share the word rheumatology and rheumatoid arthritis. But if you broaden that up more, it's more than just arthritis. Inflammation can occur in any organ, including the skin, heart, lungs, liver, kidneys, nerves, and the joints just happen to be one of the more common areas where it may manifest, but not the only one. So therefore, we focus on conditions that affect those organs, like rheumatoid and lupus and gout and vasculitis and many, many more. Our goal is to prevent any organ damage and reduce improve functional outcomes. So therefore, we want people to be independent, to be able to enjoy their lives, not be limited by any disease that might be in the background. So our hope is to control the overactive immune system back to where it was before, where it's not too high and not too low and just in the middle, like being a detective of inflammation. So how do you become a rheumatologist? This is a little preview from the first mini med school lecture and going specifically in rheumatology. So a lot of that starts with high school. I know many of us in the audience here today are in various stages of our learning curve, and it never ends, by the way. You're never done learning, but you can start off from pre-K, and I know many of us are in middle school and high school. So after you finish high school, you have your 4 years of bachelor's degree. After your 4 years, you have additional 4 years of medical school. And then you have 3 years of internal medicine residency, and then your rheumatology fellowship. I know these terms can be confusing if you never heard the term residency or fellowship. There's many different types of residency fellowships, and the timeline can be sort of 13 years of high school, but you never really think about the time. I would totally do it again, and I think most of us, I can say, would definitely do it again. It is definitely a wonderful journey that is totally worth it. So the college is your first 4 years. It doesn't really have to be in the sciences, biology, chemistry, and science, but really other majors work just as fine. You can be in arts and still apply to med school. You do need pre-med courses, so biochem, physics, math, all the prerequisites, and you do want to build your experience, whether that be with shadowing exposures, with volunteering, research is more up and coming, and then preparing for the MCAT with the ultimate goal of basically getting into medical school, which sometimes may be the hardest part. Once you're in medical school, it's divided into two halves. The first half is your classroom learning, and the second half is your clinical rotations. And both of them are equally exciting. In the classroom, you learn about the anatomy, physiology. You do have rheumatology in the classroom. Not everybody in their second half of med school will have rheumatology as a rotation, and it's wonderful if you do. But this is where rheumatology comes in. You're going to prepare for your board exams, and you're going to think about internal medicine. So to rheumatology after your medical school is going to be the internal medicine specifically residency, which opens your doors to a lot of different types of subspecialty fellowships. Rheumatology is one of them. So internal medicine is 3 years long. You'll treat a variety of adult diseases, and you'll have rotations that'll include rheumatology. And believe it or not, this is how I ended up in rheumatology. I didn't go into, when I was applying for internal medicine residency, my whole personal statement was about, I want to go into pulmonary critical care, and I love the procedural aspect and the hands-on calming in stressful situations. And my actually my first month of second year residencies when I had my first actual rheumatology rotation. And if it wasn't for that, I wouldn't have gone into it. So I fell in love, did my elective in Philadelphia. I loved it. And that's where I ended up matching. And it was history ever since. So all that goes to say, you don't really have to make up your mind from the get-go. I wasn't until my halfway through residency where I decided. So even if you're not sure now, that's totally okay. Even if you're sure now what you want to do, it might change. And therefore, so fellowship being 2 years, you really specialize in a whole variety of cases. We use ultrasound, we use procedures that are joint injections, aspirations. We do a lot of complex treatments that are oral injections, infusions, a lot of multi-specialty cases. We work as inflammation is broad, it is usually not localized to one organ, and therefore you work with other specialists, whether that be cardiology, dermatology, nephrology. For basically any organ you can think of, we often will have some overlap. And then my favorite is patient education and just actually learner education. So we really have the opportunity to not only do research and collaborate with other specialists, but we have the wonderful opportunity to train students, residents, fellows, and each other. So that educational front end is sort of where I like to be a strong advocate for. We have a case here, and I'm going to say this patient is Maria. She is a 54-year-old female told by her family doctor that she may have rheumatoid arthritis and should see a rheumatologist. So, and I chose female for a reason because a lot of times autoimmune diseases tend to be female predominant for many reasons. So when she's told by her family doctor that she may have rheumatoid arthritis, what does that mean? The arth in arthritis means joint. The itis portion at the end of any word means inflammation. So you can use itis at the end of any term and it'll mean inflammation of what came before it. In this case, inflammation of the joint. The autoimmune, when she's told by her family doctor she might have an autoimmune disease, which rheumatoid is one of them, auto means self and immune means your immune system. And normally your immune system is attacking things that don't belong in the body, whether it be infections like bacteria, viruses, and fungus, but it is not supposed to attack things that are a part of you. Therefore, when you're autoimmune, means your immune system, instead of attacking things that don't belong, it is reacting for reasons that are still under a lot of research against your own normal self. So when you think of rheumatoid arthritis, what do you really look for? There's a lot of things that are out there that can make it. Do I have arthritis? Do I have rheumatoid? Is osteo? Is it arthritis at all, or is it just nerve pain? Is it phantom? There's a lot of differentials. But for rheumatoid arthritis, if you think someone might have it or you yourself might have it, the three things that you can ask yourself from symptom is stiffness, swelling, and range of motion. If it's rheumatoid, your stiffness will last for more than an hour in the mornings. Your swelling will be in multiple joints. And I say swelling because swelling is not usually benign. And I don't mean swelling like, at the end of the day, your legs are swollen because you've been sitting in a chair for so long and there's like swelling around the joint. We're talking about swelling in the capsule of the joint itself and multiple joints that are usually symmetric, meaning on both sides. And lastly, you have range of motion that's limited, where you have a hard time making a fist or getting out of bed. The activity and rest are important as well. Whereas normally if you have wear and tear type of arthritis or something that's non-inflammatory, you generally feel worse when you're active. However, if it's inflammatory, like rheumatoid arthritis, you feel better when you're active, meaning patients feel better at the end of the day than they would in the morning, and they feel worse with rest. Steroids, I put that because they're either way. They're not very specific in helping you determine whether it might be inflammatory or not. So rheumatoid is to the right. And these are the three questions that you're going to ask either yourselves or your patients or be someone you suspect that can give you a clue and narrow it towards rheumatoid. The first one is how long does it take to loosen your joints in the morning? If they say it's more than 30 to 60 minutes, it's more likely to be rheumatoid. Second is, do you have swelling of any of the joints? If they have many joints that are swollen, whether they be small or large, that's more likely to be rheumatoid. And lastly, do you feel better with activity or worse with activity? If they feel better with activity, it might be more likely to be rheumatoid. So what is RA? Maria is told she has it. It's inflammation of the joints, the arthritis. It's where the immune system reacts to the lining of the joints. There's many different parts to a joint. This specifically is the lining within the capsule of the joint. And therefore, it can be affecting any joint that has a lining. That include hands, feet, wrists, elbows, any joint you can think of has the potential to be involved. But doesn't mean all of them have to be active at the same time. It's just whatever may be active at that moment, in that flare or whatever might be active. So the symptoms include inflammation of that joint that may be felt like pain, stiffness, swelling, and limited functioning. So now Maria sees you after seeing her primary care physician. She sees you in the clinic. She first tells you that it happened actually a long time ago, several years ago, but thought nothing of it. I mean, how many of you had aches and pains? You're like, oh, it's probably nothing. But then you don't think about rheumatoid arthritis as your first thought, but often it is very insidious. It's not like you're flaring from nothing, and often is can be very mild. So over the last 6 months, however, she noticed that it's been worsening, where the swelling in her hands has been more progressive. Stiffness is now lasting several hours. That is better. And she has trouble opening jars. It's a very common one. You feel like you have a hard time, cooking, combing your hair, doing daily activities. And then the labs from her family doctor before the appointment were positive for both the rheumatoid factor, the RF, and the anti-CCP. That's a peptide citrulinated. You don't really have to know the acronym, but just know that these two are the most common ones. Not the only one. There's actually a lot of blood tests for rheumatoid that we don't commonly do clinically. There are a lot of research labs that will do them. There's proprietary tests that do some of these panels, but for the most part, these two tests are going to be the ones that you're going to want to get if you're thinking of rheumatoid arthritis. Almost everybody will have them, an RF or rheumatoid factor, anti-CCP. If you have both positive, the specificity is above 95%, and it's very likely that it's rheumatoid. If they're both negative, you can still have rheumatoid arthritis based on clinical symptoms, but it's nice when they're both positive. It makes your diagnostic process easier. So Maria, with both of hers positive, is now diagnosed with seropositive rheumatoid arthritis. She still has rheumatoid. It just means sero meaning serum, meaning blood. So she has these positive blood tests. That means we can classify the rheumatoid as seropositive rheumatoid type. So this 5 years ago, you happen to have x-rays, and this is what her hand looked like. So her right hand in this picture, you can see this is her knuckles, and these are the fingers, and this is the wrist. These are the normal bones of the wrist, and you can see the normal empty spaces. They're not actually empty. These are cartilage, and the x-ray only shows bone. So the empty spaces are not like floating space, but this is where the cartilage that helps move the joints and lubricates them in some ways, that is all these spaces. And you can see how smooth they are, especially in the knuckles. In rheumatoid, it tends to be more in the knuckle region. Then you can see how smooth the bones are with normal spaces between them. In osteoarthritis, it tends to be more of the tips involved as opposed to the knuckles. And on the hand, this is basically a normal hand on the right. This is what they are now. So from 5 years ago to now, you can notice that in the knuckle region, notice how the space is not there. Like here, you can see the cartilage, but notice how advanced that is. And in the wrist, notice how hard it is to see the spaces and the cartilage between it. On the other side, we can see how there's erosions and that narrowing, where the bone has the inflammation on top of the bone has over time basically eroded or dug a well, if you will, into the bone. And it takes a long time to do that. It takes months to years. And you can see the swelling over the knuckles on the picture on the right. So the synovitis is the hallmark for rheumatoid arthritis. So syno meaning synovial lining. So in anatomy of any joint, we have the two bones, the cartilage in the middle, and this lining, the red part here, that's a synovial lining. And that's what makes your lubrication in the joint. When you feel like you have water in the joint, that's what makes that water. So itis, like I said before, means inflammation of whatever comes before it. So the synovial lining, it's inflamed, is synovitis. And that's what you would see. And that's what all of this is. And that's the synovitis. So If you don't treat rheumatoid arthritis, and this is what sometimes used to happen decades ago, this is what it would lead to. The inflammation would continue to occur in the lining of the joints that would basically eat away the tendons, the ligaments, and the bones underneath those joints. So in this X-ray, you can see that there's these deviations. That's because of the ligaments and tendons being torn away. And then we have these bones that are very much eroded significantly. And you can see how these deformities have happened. So if you or someone you know has rheumatoid arthritis newly diagnosed now, rest assured you don't reach this point. This is what could happen and sometimes used to happen, but not anymore because we have much better treatment than we did before. So there is hope. Compared to several decades ago, patients with rheumatoid arthritis now have a much better chance of full recovery. And that means basically a good chance of having no damage, no deformities. You don't have to worry about being in a wheelchair or am I going to be using a walker or crutches and stuff. Not really anymore. We have much better ways of controlling it. So in fact, if you have someone who is normal and someone who's newly diagnosed, you basically won't be able to tell one from the other that one has rheumatoid and one doesn't. So it's very effective. We're not at the stage of a cure just as yet. Like even some cancers now have early cusp of cures, and we'll get there. Rheumatoid arthritis has very good treatments, and these treatments prevent disease progression and can control it in remission. I'm hopeful we'll get a cure, but perhaps not in our generation, but I'm sure we will at some point. So the first line treatment, the goal of preventing the damage and reducing, improving Maria's activity, usually is for moderate to severe disease, usually is methotrexate. And you probably have come across that. If not, you will at some point in anything rheumatology related. It is a very common. It was actually first used for treating cancer a long, long time ago, but it was found to have anti-inflammatory effects at much lower doses. Instead of thousands, we use anywhere from 10 to 25 milligrams once a week. So it can be very variable. It comes in oral tablets, liquid to drink, or injectable in vials. And liquid is common because of pediatric. If you have young kids with juvenile rheumatoid arthritis, then they're not able to take pills. So it's very variable. It is not chemotherapy. I want to clarify, a lot of people get confused about methotrexate because if you read online about methotrexate, like many drugs, they have multiple indications, but the drug is the same. So if you're reading about anything online, yes, it's true that it's not false. However, in the right setting. But the doses that is used in rheumatology are significantly less and generally well tolerated. However, it is important to note that it is potential side effects include mostly upset stomach, GI, nausea, ulcers, and we always look at liver and organ function. So almost all patients will have labs every 3 months looking at their blood counts, liver and kidney numbers. But this is usually the anchor foundation for and usually some countries actually only have this for treatment. So if you have mild disease or if you want to combine it, the other commonly used oral options are hydroxychloroquine. I'll mention the brand name because you may have heard that instead, Aquanil. It is for mild disease, and this is one is daily, either once daily or twice daily. And sulfasal's is another common one. So these are all the oral options where they can be used of something what's called triple therapy, where you can combine methotrexate with hydroxychloroquine, sulfasalazine, and that is effective. Yes, it can be a lot sometimes, but it is as effective as some of the injectables and biologics. But she's still swollen. So Maria got triple therapy. It's been 3 months. She's still swollen. So she's now prescribed prednisone, 40 milligrams daily for 5 days. For those who are not familiar, prednisone or Medrol or methylprednisolone, they're all in the corticosteroid or steroid category. Now, it's okay to, most people, if depending on what you hear, steroids you think of, these are corticosteroids. Now, some people think of steroids as the anabolic steroids, like steroids that you're using to, build muscle. There's 3 different classes of steroids. And when I mention steroids, we're generally referring to corticosteroids or glucocorticoids, which are the anti-inflammatory type of steroids. And prednisone is the more common of the oral types, and it's used for a variety of inflammatory. Basically, it's sort of like almost like a nuclear bomb. It's very, very broad in inflammation, which is why it has all of those side effects. So, and you do use it, but only for short periods for flares. So if she's swollen and can't function, it's okay to use prednisone for short periods. So if you're given 40 milligrams, range, a low dose is like 5 to 10, moderate is 20 to 40, high is like 40 to 60. Just given 40 once daily with food for 5 days, which helps, but it only helps for the time that you're on it. So it's only used as a bridge. It's quick, which is the best benefit. It is improves quickly. It is improves function. It helps you transition to something else that is more long term, but takes more time to kick in. But that's really where the side effects come in, because the longer you use it, the more risk you have of weight gain, of high blood pressure. If you're diabetic, it raises your sugars, weakens your bones, increase infection risk, mood changes. And if you're on a dose anywhere from more than even 5 milligrams, it generally, I'll just mention the word mortality, it increases it. So you don't like to use rather prednisone or glucocorticoid unless you need to, but the benefits sometimes do make it appealing, especially for short courses. So it's rapid, helps for flares, helps you work, not miss time with your family, and to take and not basically avoid the hospital visit if you can't take care of yourself. So the lowest dose for the shortest course is the goal. But she still has active disease. So what do you do now, right? This is where the next step of available options come in. If you want to help Maria become functional, independent, and pain-free, this is where we can have the specialty medications come in. And that's where Amanda will come in.
Yes, so Maria needs some specialty treatments now. And before I begin with that, I did want to take a moment to again reintroduce myself. I'm a clinical pharmacist that works for the Christiana Care Specialty Pharmacy, and I specialize in rheumatology medications, which is why I work with Dr. Verma at the rheumatology office. And for those of you who are curious about pharmacy as a profession, for those of you who are interested in drug science and pharmacology kind of thing, the career for pharmacy is amazing, and it's more than just what you might be used to in the retail traditional setting. And so what the career path looks like, there we go. So pharmacy school is a 4-year doctorate degree, and typically you need to have an undergraduate degree to get in, but there are some accelerated programs that you can enroll into a pharmacy school 6 years right out of high school, and I believe there's some of those programs in Pennsylvania. And then if you're interested in clinical pharmacy, it's recommended that you do a residency or fellowship after graduating. And we actually have several residents at Christiana Hospital right now, and they are rotating through each month different areas, like let's say the cardiac ICU 1 month, the oncology unit the next month, infectious disease, and so forth. So you really get a really well-rounded experience, and then get to kind of decide if you want to specialize in a certain area. And then as far as opportunities, you have your traditional community-based and hospital pharmacies. If you are looking to do more clinical things and provide direct patient care, there are opportunities both in the hospital and in the outpatient setting like myself, where you do primary care, or there are other specialized areas. You could work in industry like drug companies or research, insurance companies, and there are a lot of great leadership roles for pharmacists as well. So back to Maria, she needs to start specialty treatment. And the options here are parenteral and oral options. Parenteral just means any medication that you inject or infuse. And so for the parenteral options, we have our biologic DMARDs. So DMARD is an acronym for disease-modifying anti-rheumatic drug. And that means that these medications actually modify the disease course by slowing down or stopping the progression of the inflammatory disease. And then biologic means that these medications are coming from living cells. And these biologic medications have really been a game changer for patients with rheumatoid arthritis. So how does the biologic medication work? So from these living cells, they're able to create lab-made, genetically engineered antibodies. And why antibodies? So antibodies with antibodies, you can create a very specific target. So our own immune systems create antibodies against a specific pathogen. Let's say you have a virus enter your system, your body will create an antibody for that specific virus, target and bind to it, and then your immune system can come and destroy that virus. But in patients with autoimmune diseases or rheumatoid arthritis, the virus is not the pathogen. The pathogen is the activated immune system that is causing damage. And for Maria, it's to her joints. And so what they do is they create these lab-made antibodies that target specific immune proteins or molecules in our immune system that are contributing to the inflammation that's causing rheumatoid arthritis. And so with these medications, we're able to calm down that part of the immune system and quiet it down so it's not causing the damage. And so it's really cool to have something targeted versus something more broadly suppressing the immune system. But these medications have to be injected because if you were to ingest them like an oral medication, they'd be easily broken down by our digestive system. So there are obviously patients who do not want to inject themselves. So there's a lot of research into finding an oral medication that could also be targeted. So the oral options we call are the targeted synthetic DMARDs. Synthetic meaning that it's chemically made, and targeted meaning, again, that we're targeting a very specific pathway. These work within the immune cells to block a precise pathway that would lead down to downstream inflammation. So again, it's really nice to have a targeted option. Next slide, move forward. There we go. Okay. So for injections, I listed the brand names here just because you might be familiar from commercials, seeing especially like Humira, which has been a blockbuster drug for over 20 years. And what Humira is doing, its target is tumor necrosis factor. So it's blocking that. So we call it a tumor necrosis factor inhibitor or TNF inhibitor. And you can see what TNF is and the other targets I've listed here with interleukin-6 and T cells. You don't have to remember those, but these targets are all crucial parts of the immune system process, which could lead to downstream effects of inflammation. And so as far as administration, these are administered as at home by the patient as a syringe device, which I have an example here, or a pen device. And these pen devices are really user-friendly. A lot of patients, after they come into the office, I'll teach them how to use the medication and they feel very comfortable using them at home. And they just get injected under the skin into their stomach or the front of their thighs. And they inject every 1 to 4 weeks, depending on what medication they have. And typically patients are getting full effect 3 months from starting the medication. And the effect can be robust. So patients can get an amazing response, let's say to Humira, and continue that for many years. Some patients might see a partial response, in which case we might, maybe switch to another medication within that same class. As you see, we have 3 other options alongside Humira there in the TNF inhibitor class. Or if the patient doesn't respond at all to a TNF blocker, we can try one of these other targets. It's really great that we have multiple options here. As far as safety, we counsel patients that infections could occur. That could be the common cold, sinusitis, or it could be even more severe infections, but it's rare. But when those infections do occur, we ask the patient that they stop their medication during that time because it is harder for them to fight off the infection while they're on these medications. And then injection site reactions could occur. We just mean some redness and a little bit of swelling around the injection site, which go away. And then there are infusion options. These are medications that are injected through the vein, so intravenously, and that can happen at an infusion center or it can be done at home as well. So the home would look like. An infusion center would send out a nurse with the medication, and you could receive the medication in the comfort of your own home. And for the options here, you see we Actemra and Orencia you saw on the previous slide. So those are available both as a subcutaneous injection at home and an infusion option. And then we have another TNF blocker agent, Remicade, and then another target with B cells with Rituxan. Now, why would we choose an infusion over injection, home injection? Maybe one reason would be that these infusions allow for weight-based dosing. So you're giving the patient the dose specific for their weight, and that could be beneficial for them, as opposed to our injection devices, which typically are only one dose. Maybe there might be a second dose option available. Another reason for an infusion is that it might be insurance dictated. Maybe your insurance prefers, or it's cheaper to get an infusion versus an at-home injection. And then just patient preference of which one, infusion versus injection, they would like. And then we have our oral treatment options, our targeted synthetic DMARDs, and the three listed here all work very similarly. They are one tablet you would take once or twice a day, and they work fairly quickly, as early as 2 weeks for patients. There are some additional safety concerns with these drugs. When they were compared to the class of agents like Humira, there was a slight, rare but slight increased risk of heart attack and stroke. And so because of that, there are some prescribing restrictions on these medications, and that you should really try an agent like Humira before starting one of these medications. So we prescribe Maria Humira, and we send that to her local pharmacy as requested. But when Maria gets there, they tell her, hold up, we can't dispense this. This needs to go to a specialty pharmacy for dispensing. So Maria's like, what's that? So all the medications that I've been talking about are considered specialty medications, and as such, need to be dispensed by a specialty pharmacy. So what are specialty medications? These are high-cost medications, meaning several $1,000s per dose. They're high risk, meaning they might need extra monitoring, extra screening, extra counseling, special storage requirements, special administration requirements like the injection and teaching somebody how to do that. So because of this, insurance requires that these medications are dispensed by a specialty pharmacy because they are accredited to handle these high-risk medications. And what those specialty pharmacies are responsible for is that they have to thoroughly document that the drug and the dose is appropriate for the indication. They're screening for drug interactions and drug compared to the patient's comorbidities. For example, if the patient has kidney disease, does this dose of medication need to be reduced, or does this patient have heart disease and we're prescribing a high-risk drug that might cause heart attack? So screening for those certain things. And then lastly, a pharmacist must educate the patient before the patient ever receives the medication. And also they're responsible for following up with that patient to make sure the medication remains safe and effective. And that just occurs through follow-up phone calls. Christiana has our own specialty pharmacy, and we have pharmacists like myself embedded into the specialty clinics so we can assist those providers with these specialty medications that they are prescribing. So we have pharmacists in endocrinology, pulmonology, neurology, behavioral health. And outside of Christiana, there are other big name specialty pharmacies. You might have heard of CVS Specialty or Credo. And so we get the medication to her specialty pharmacy, but then that pharmacy says, well, we can't dispense it yet because we need a prior authorization. And you might have heard this at a pharmacy before. So a prior authorization means that your insurance will not pay for the medication until your doctor gets approval. And it's a process used by health insurances to control costs. Because as I mentioned earlier, these are expensive medications. So to continue with Humira as the example, Humira costs about $86,000 per year. And so the insurance companies want the physicians to put the information to them that this is medically necessary. So they want proof that, they'll ask questions like, has the patient tried methotrexate as a potentially more cost-effective option, since methotrexate would probably cost $300 to $400 a year to the insurance company. They'll make sure that we're dosing in line with FDA and we're in line with national guidelines. And they want to make sure that we're submitting data that's patient severe enough to require Humira. And then lastly, what they consider is this drug on our drug formulary? And so again, with Humira as the example, there were 3 other medications within that TNF inhibitor class creating competition. And so the insurance company is looking for the best cost. So they might make a deal with Simponi, as an example here. This insurance company said, we made a deal with Simponi. We're not going to cover the other medications within that class. And so we won't cover the Humira. We'll ask the prescriber to change the prescription to Simponi. And of course, this sounds great. We really do want to reduce cost of drugs. But the concern is that there is treatment delays. And so the prior authorization process requires a lot of back and forth with the insurance company, a lot of paperwork, faxes, phone calls, trying to explain why the patient needs the medication. And when the prior authorization is denied by insurance, then that's when we have to pursue appeal options. And this is where your debate team skills come in. You're going to submit an appeal letter explaining why therapy is warranted in this case for this patient, and you'll provide clinical data, literature studies, or you could set up a peer-to-peer call, which means that you set up a time to speak with a clinician who works for the insurance company, and you have a discussion about why this patient meets criteria for medical necessity for this drug. And 9 out of 10 times we can get the medication approved. But again, the patient unfortunately is waiting days, weeks, sometimes months for the medication to be approved. And so there's that treatment delay that's unfortunate. So we get insurance to approve Humira, but the pharmacy is saying, well, we have to switch it to the biosimilar. So what is a biosimilar? So you could think of a biosimilar as a generic formulation of the biologic, but we can't call it a generic. So a generic medication is identical to the chemical compound of the brand name original medication. So, Advil brand name is the ibuprofen is the generic name for Advil. But biologics are not identical compounds because they are developed from living cells. There is an expected variation in that manufacturing process. So there might be slight changes to the protein molecule, but it has no effect on the drug's ability to do as it did, as the originator product did. It has the same efficacy, same safety, and it goes to the FDA to prove that. So we say that a biosimilar medication are very similar, but not identical to the original biologic. Again, they're made from the same living source, provide the same benefits and side effects, same dosing, same administration. So we feel really comfortable transitioning patients to biosimilars if the insurance is dictating that. And because so many biosimilars are coming to the market, creating that competition, again, insurance companies are looking for the best cost. And so, with these drugs coming to the market, the costs are coming down, which is great. But of course, they're still very expensive. So we finally get Maria, her Humira biosimilar. It's approved, and she is told that her copay is $1,200. So Maria is freaking out a little bit after all these hoops. Here we are. So she calls the office and we are able to go through and provide her the financial assistance options. So there are copay cards available, and those are for your commercially insured patients. Those are like employer-based insurances. And those copay cards can bring that $1,200 to $5 a month copay. And then for those patients who are government insured or uninsured, there are drug manufacturer assistance programs. So we help patients enroll into those, and if they're eligible and meet the income criteria for those, and those programs are very generous, those patients get the drug shipped to them directly from the manufacturer for free. And so to conclude, we just wanted to demonstrate that the challenges of not only getting the patient the right medication, but the process, the challenges that we go through in order to obtain that medication for that patient.
For reasons I don't understand, my video wouldn't come back on. I'm so sorry about that. All right, we have a number of questions. Great presentation. All right, here we go. Well, I'm going to start with one of my own. Can osteo and rheumatoid arthritis occur simultaneously? And you may have covered this and I might have missed it, but if so, how does that complicate a differential diagnosis, and how do you proceed with treatment when they're both present?
It's actually a very, very good question. It's also common. It's not that it's not unusual at all, actually. It's osteo just means bone, arth means joint, as in inflammation. In osteoarthritis, the itis inflammation is more of a reactive type. In other words, the immune cells are trying to heal and repair the wear and tear part of things, if you will, which leads to the outcome of bone spurs and narrowing of that cartilage over time, which gives you that bulky the nodules in the tips of the fingers. It's different than the rheumatoid arthritis, where the itis in that part is the source of it. So it's not that the bone changes came first that led to the wear and tear. It's that the inflammation was the source of that arthritis. The demographics are helpful because in osteoarthritis, yes, it's older population. So someone who's like 20 wouldn't be expected to have osteoarthritis. And if they do, that's rheumatoid. But rheumatoid has like bimodal distribution. It can be in the 10s and 30s, but it also be more common. The peak incidence is about 70s and 60s. So it's very common to be actually together, and you can tell by the distribution. A very simple way is if it's in the knuckles, it's rheumatoid. If it's in the tips, it's mostly osteo. Osteoarthritis doesn't have labs that are positive, so both the RF and CCP will be negative, versus they're both positive, it's rheumatoid. But if you clinically, usually if it's the tips involved, it's osteo. But if they have the tips involved and they have knuckle swelling, that's a clue that there's both together. If they have the wear and tear in other joints, then you know a positive blood test shouldn't be osteo alone. And the stiffness and swelling will be a clue. If you're swollen in multiple small and large joints and your stiffness is more than an hour, it's rheumatoid. But if it's less than 30 minutes, it's mostly osteo. So you can tell them apart clinically, but it is very common to be, especially as in the older demographic, it's common to be overlapping.
Yay for the older demographic. Tell us about the hereditary nature of either forms of arthritis, for the particular rheumatoid arthritis.
Great question, because it's not actually as hereditary as you might think. Rheumatoid arthritis in family, it doesn't mean that if your parents and your siblings have it, yes, there's a slightly higher risk, but it's not like a fully penetrant. So in fact, I think osteoarthritis may be a little more so, where parents who have osteoarthritis, the children are more likely to have earlier in onset, earlier in life osteoarthritis. So it is to some degree hereditary, but it is not actually confirmed at all. So it's very plausible to have both parents with RA and the kids are totally fine. And that's because of the penetrance. So they're both halflings, but not in a way that so you don't have to be worried if you're like, oh, I have 10 people in the family. Am I going to do it? It's not necessarily true.
All righty. And then and along the same lines, do childhood bone or joint injuries often become some form of arthritis later in life?
Also a good question. Believe it or not, and every time we see pediatric inflammatory arthritis, they actually don't feel pain. I'm very surprised and impressed every time I see it. These are like these 3, 4, and 7-year-olds. They're clearly swollen. Their knees are swollen. Their hands, but they're smiling and running around and crawling on the floor. They don't feel pain. So inflammation in kids is actually painless, which is what makes it remarkable. But injuries are a little bit separate because injury implies a mechanical source as opposed to the inflammatory source. So yes, to some, but not generally, not in the way that you think about it. Kids who are playing around doing sports, I wouldn't say that. It's different for hypermobility for those who have hypermobile joints, who are like the double jointed, if you will. Like the Erlos, Danlos, and those spectrum, they have a higher risk for earlier than normal osteoarthritis type, but not the rheumatoid. So if you have injuries, from whether that be however hyperactive or active you may, or athletic, but I mean, that's totally fine. A great example is running. Like people think like long distance running is going to cause osteoarthritis, and you can hear your knees, but it's actually yes, but not necessarily. So kids can be totally active and not be concerned about developing like certainly not rheumatoid and even osteoarthritis, not generally.
So kids, this isn't to our younger viewers or younger students, this isn't an excuse not to get outside and play and run and stuff. Question from Honor. Once the immune system has been programmed to attack your own body systems, is there a way to make it forget that antigen similar to the way the body forgets colds?
Do you want me to answer, Amanda, or you want to question? That's it's a good question because that is what the cure would be. So when I mentioned treatments, you can think of, to use a different analogy, you can think of it like a volcano. When you have a volcano that's erupting, that's your flare of a disease. And your treatments are to prevent that eruption from happening. A cure would be to not have the volcano at all in the first place. But you can still go to a place like Hawaii and enjoy your vacation and volcano just be there in the background. Like that's not going to, just being there is not a bad thing. So having rheumatoid arthritis by itself is not a bad thing as long as it's not actively erupting and making everyone evacuate. In the same way, having been exposed to something that you're reacting to, like an infection, that's a good response because eventually the infection goes away. So having that memory is good because that memory means you can clear it at a future exposure. But if you are reacting to something that doesn't go away, like things that are part of you, then that a cyclic trigger is what gives you the cycle of inflammation over and over again. So the different treatments that Amanda and I mentioned, they're basically targeting, basically like snipping the wire. The classic movies where you choose the wire that disconnects the bomb from exploding. These medications basically snip different wires of that system, like a link in the chain of your bicycle. You're moving your wheels. You're pedaling and your wheels are moving. You can choose any link in that chain, and that's what the different medications target. They just basically target different links. It doesn't really matter which one you take off. The chain comes apart. That's different than not having the memory in the first. So a cure is what the other part of the question was. If you just forget to react to it, that's where we do have some treatments. And you're talking about genetic therapy and stem cell therapy. I think we'll probably get there at some point. So genetic therapy is going to be the next frontier where you can program the cells to just not be reactive and not have those receptors. And that's probably where the cure is going to come from.
Right. And actually, there was a question in here from Lori about can medication be more specialized to fight the specific disease if it was based on the patient's DNA? And I believe what I just heard you say is yes, probably so, under development.
There's a lot of research. In fact, a lot of cancer research, the whole immunotherapy is that's all it is. Immunotherapy is basically removing the brakes of the immune system to use your own cells to clear the cells that don't belong. Either it be cancer or in autoimmune cells.
Right. Okay, I think Christy's going to take over the questions.
Sure. Kristen asks, how prevalent is RA in children and young adults?
Oh, how prevalent is it? It's actually, it depends on who you ask. There, of course, the pediatric rheumatology are going to see it a lot more. So it is one of the more common ones. In fact, rheumatoid arthritis is probably the most common autoimmune disease that prevalence worldwide, and especially also with juvenile portion. So it is prevalent, but I think if you're in the general population, I wouldn't think about every joint pain as a rheumatoid arthritis part. I'm assuming that's where the question's coming from. Like, does my kid have RA? Is juvenile? And the answer in the general population would be no, but you can tell if you have those three things, the swelling, especially in kids, you can't tell stiffness. You really can't tell. They're going to be around, but swelling is what gives that away.
Oh, thank you. Lori asks, what is it that eats away at the ligaments and or muscles that causes the deformity of the bones?
The synovium. So the synovitis, the itis is the inflammation, and inflammation is coming from those immune cells. And inflammation is basically anytime immune cells are active. So if you have an active immune system, you have inflammation. And that inflammation, like, you wouldn't live without it. Like you fight off infections like a pneumonia or UTI, whatever. That's through inflammation that your immune system works in the first place. It's only when it's active against things that don't need to be active against, like your joints. So when you have inflammation of the lining of the joint, that over time, all those acidic responses that are used to fight off infections, the same thing are active inside the joints, which it can fight off to a certain degree. You have resilience, but over time, that inflamed, thickened lining is going to basically grow and affect the ligaments that are on either side, the tendons that attach to the bone, and eventually erode into the bone themselves. So it's the thickened lining. All those inflammation cells have these peroxide little small pockets that you can think of like acid. It's basically literally like acid that slowly over months, this period takes like 3-6 months longer, that's what erodes into the unprotected parts around the cartilage that isn't as protected in the bone.
I like this question. How big of a role does diet play in getting RA? And I'm going to add in treating some of those as well.
Amanda or me?
I mean, I feel like the jury is a little still out on the diet. There are anti-inflammatory diets, and the data, there's positive and kind of negative data with following patients for any autoimmune disease and whether like diet helps. But I guess patients who do try there are some patients who start an anti-inflammatory diet who say it made a difference for me. So that is like kind of like avoiding your like nightshade vegetables, your eggplant, tomato, that kind of thing. Those promote inflammation. And so some patients who try that, I say go for it if you want to try it. I have a lot of patients who, when they're starting their new biologic, ask me about the diet as well. And I print off the information from like national resources and say, this is the diet that you can try. And if it works, then that's great.
Oh, kind of along the same line, the same individual is asking, is ginger and turmeric just as effective as drugs, or do you need a very high dose of them to get the same effect?
I think in that regard, like ginger and turmeric have been anti-inflammatory notice, and my approach is very similar to Amanda's in that I'm certainly definitely not opposed. And I'm all in support, very holistic. And there's actually a whole branch of science that deals with just this, whether that be homeopathy or whether that be in the realm of nutrition medicine. It is up and coming. There's a lot of advocacy in making that more into the mainstream, and that's certainly fully on board. To the answer to the question about the potency of it, I usually will say it's naturopathic and homeopathic and supplements are generally not going to be enough to make a big difference when you have a quality of life moments. For example, if you're swollen and you can't make a fist to like brush your teeth, I wouldn't expect the ginger and turmeric to be making that difference. However, if you have mild case where you have low risk. Low risk meaning low risk for having deformities, erosions. You're not having active moderate to severe disease. Then it's certainly in. I'm never opposed to having that as a first trial. And if it doesn't work, give it 3 to 6 months, and for sure, let's move on and combine them. There's nothing saying you can't do one without the other. You can be combined and very flexible. So I'm not opposed to it. And I will, full disclosure, I will not claim to be an expert in homeopathy and supplement medicine, but I fully understand and appreciate the science that is evolving.
And my only addition is that to make sure that the supplement's coming from a good source. And so those supplements will typically have some sort of certification on the label, because the FDA is not reviewing the manufacturing process of these like herbals or any type of supplements over the counter, drug supplements over the counter. And so just making sure that it's certified by a good manufacturing site.
And then we have another question that says, do you think CRISP will help in the future to cure autoimmune diseases?
I almost certainly think it will play a role, if not the dominant role at some point. Most probably, there's a lot of legal and ethical debates around that. But I think that's going to be a part of that treatment algorithm where we'll look back how we, like right now we look back, oh, we used to use gold back in infusions back 30 years ago, and we'll be like looking back 30 years from now, like we used to use methotrexate and what? You know, I'm sure it's going to be that at some point. We like to say we're modern, but we're actually still in the Stone Ages.
Tim, do you have any other questions?
I
There's a few in here.
Yep, let me jump back in. Sorry, just overwhelmed by the questions. Okay, oh, here's a good one. I'm going to direct this to Amanda. Why is it that the same drugs cost so much less in other countries as opposed to in the United States when they come from the same manufacturer?
I do not have an answer for that. But apparently that might be changing.
Yeah, I think my supervisor just decided to hop on the computer. I think that there's some legislative action going on to attempt to equalize this that is a long time in coming. One of the concerns that pharma have expressed is that without the large revenue stream from the American consumer, it will ultimately impact research and development to modify and tackle, new diseases and create new drugs. But it is certainly, as with just about everything in healthcare, an incredibly complicated issue.
Yeah, I was actually going to be able to add to this. My cousin works for a pharmaceutical company that also works with like US. It's a partnership with as I can't even talk anymore. AstraZeneca. But she's actually located in Poland in Europe. So for example, one of the things, and her and I have talked at length about this, like, I don't know, Ozempic, which is like pretty famous here. Over there, it's like $40 a month to have Ozempic. Yeah, I know, Tim. And here, as you know, it's like 1,000 and some change. Like you have to sell a kidney for it. And the biggest issue is that in the US, there isn't really any price controls, and pharmaceutical companies can kind of just put whatever price tag they want. And that's a large reason as why they're able to, put that high price tag. And they know that, especially things like GLPs, they know people will want them and want to buy them, and there's a market for it. So a lot of it has to do with government legislative lack thereof, I guess you could say. So the lack of price controls and dictating what prices are allowed is probably the main issue there.
Capitalism at its best or worst.
Yep, there you go.
Okay, are trigger fingers related to RA? What are the causes, and is it genetic?
The trigger finger can be a feature of RA. However, they're not directly linked together. For those who don't know, if you have a finger, I'll just use hand. You have like when you make a fist, for example, the tendons don't pop out. Otherwise, you would see the tendons just straighten out, but they stay anchored. And the way that they stay anchored, for example, in your creases, is because you have basically tethers or pulleys that anchor. It's like a staple. The staple is one here, one here, one here, so that when you bend, it acts like a little fulcrum. So it allows the finger to bend without actually the tendon, the force being broken away. So a trigger finger is when the tendon sometimes gets stuck in either the A1, 2, or 3 pulley. So usually it's the most common is the one here. And if you have an irritation, repetitive movement, injury, whatnot, then the sheath of the tendon, it has an outer layer. Sometimes so when you're pulling the tendon, it'll get, the nodule will be on this side of the pulley. When you try to open it back, it'll have a hard time going through that narrow tunnel, basically. So you can conservatively manage is fine. Over-the-counter things, topical. Local injections are not often needed, but totally doable. Last resort, you just release the tightening and open it up to open that pressure. Rheumatoid arthritis can be affected because the tenosynovitis, which is inflammation of the lining of the tendon, can occur, which makes it thicker to go through that sheath. However, it's not as common for trigger fingers. I think oftentimes you think of carpal tunnel more because of the tendons here before they get there. And a lot of times people end up doing carpal tunnel surgery because they think it's just carpal tunnel, but the cause was rheumatoid that could have prevented that surgery in the first place, but not exclusively. So you don't think of rheumatoid as your first thing for trigger finger. To answer that question, was there a second part to that?
No, I think you got it. I thank you. I frankly, I've heard the expression before, but had no idea what it actually meant. So a follow-up to that, can carpal tunnel or repetitive motion lead to arthritis?
There's a lot of studies, and I think that the more famous one is the person who researcher was like cracked the joints on one side and not on the other, and like 30 years later there was no difference. Repetitive movements in carpal tunnel do not lead to arthritis. I think repetitive movements as a whole, I'll put that as a grain of salt because of course, the classic selection bias is osteoarthritis is more prevalent in patients who have manual labor, who have done household cleaning for 30 years, construction jobs, anything that is more laborious in their hands. However, the opposite is also true. You can have someone who did a desk job their whole life and still have osteoarthritis, right? So it's not to say that we tend to remember our selective memory, our recall bias is more towards the patients who have had those experiences, but it is not to say that it's going to happen. And you'd be surprised, if you do MRIs on people, like for example, if you did an MRI of someone's back, you will find something. It's not like it's not there. There will be some changes in the bone, but that doesn't mean it's a disease state. And having the disease is different than having a very preclinical thing. That's a general rule. I would say no as a whole, but of course, the wear and tear part, it is, yes, to some degree, but not in the sense that researchers still, believe it or not, osteoarthritis hasn't had the same level of development as rheumatoid has. We still have the same drugs for OA that we did 10, 20 years ago. It's more than just wear and tear, which is what I mean. The repetitive movements and motions are not the only thing. There's more to it. There's genetics and there's some even inflammatory process in osteoarthritis that we don't fully understand. So the short answer is maybe, but not really.
Okay. So I almost feel like this is a trick question, but I'll ask it anyway. Seropositive rheumatoid arthritis was what one of the examples you talked about was diagnosed with. Is there such a thing as seronegative rheumatoid arthritis?
Neither me.
Oh, well, I think you had spoken about it on one of your slides. So he had talked about rheumatoid factor and CCP positivity. So if those are negative, but yet the patient meets other clinical criteria for rheumatoid arthritis, then they are considered seronegative, serum blood, and then negative rheumatoid arthritis.
And I'll forward that on because Amanda did a great job explaining the target and the antibody portion. So when we say seropositive, seronegative, we're basically limiting our seropositive to the commonly used clinical blood test. But rheumatoid has to have a a trigger. There must be antibodies that trigger this in the first place. It is an autoimmune disease by definition. So when we say it's seronegative, we're basically saying that they're negative for the blood tests that we have commercially available, but there are antibodies present that must be there for the rheumatoid, but we just don't have the test to test for them. And you might have a comprehensive test in a research lab. So seronegative doesn't mean that they don't have the antibodies at all. It's just seronegative for the test that we do in the clinic, like, for example, those two. It's more of just a cost to effective rates. You can capture a great percentage of population with those two tests alone, and adding those 10 things at the cost is not worth that effect. So seronegative still has the blood test, and you could probably check for it, but negative based on the tests that are with those two.
Right. So thinking about older adults and thinking about some of the chronic disease dyads and triads, does rheumatoid, or for that matter, osteoarthritis, typically express with other chronic diseases as a causal relationship rather than a coincidental relationship?
Most people will think of the term connective tissue disease when answering that question. So a connective tissue disease is like this overarching term of, when you think of arthritis, for example, or you can think of a disease, that's the broadest you can go, a disease. Then you have like an autoimmune disease and a non-inflammatory disease. So an inflammatory disease, you think of you can think of any part of the body and you can have a reaction to it. Like your thyroid is an autoimmune thyroid disease. How many people have Hashimoto's, right? That's a lot. Multiple sclerosis, your pancreatitis, like there's so many autoimmune you can think of. So rheumatoid is one of that autoimmune spectrum. And the theory generally is that if you have one, there's an increase in the probability of having another autoimmune disease, and rheumatoid can fall into it. So the undifferentiated or different connective tissue diseases, of which rheumatoid can be a part of. There are, you classically think of like Sjogren's and lupus and scleroderma, all the different connective diseases, they tend to be associated with it, but not directly from a causative sense. Now, they are like HLA epitopes, which basically just means genes that are common to rheumatoid arthritis that coexist in other areas. For example, like inflammatory bowel disease is common and can coexist with inflammatory arthritis. But the short answer is yes, they're very commonly associated, but not necessarily causative.
Thank you. Speaking of connective tissue diseases, and something that we certainly casually hear about a lot is fusion of joints. Can you tell us a little bit about the relationship between rheumatoid osteoarthritis and fusion of joints, whether it's done to solve the problem or whether the body does it on its own?
Oh, I see. I think when I think of fusion, I think of the ankylosing spondylitis part, but I guess fusion can also be therapeutic because you do spinal fusions, and they're very different. So when you think of fusion from inflammation, if you think of 2 sticks of butter and just, pull out 2 sticks of butter in your fridge and they're cold and you can slide them, and you do the 2 long ones and they slide right off. They're slippery. They're very they're very mobile. They're very fluid in that way. So, and you think of inflammation, imagine putting a hot knife between those 2 sticks. And that hot knife is what inflammation basically is. So when you first cut through, that hot knife is going to slice right through. And your 2 sticks will still be mobile. You'll still be able to move them. They'll still slide over and over again. But over time, when that area cools down, you're going to have some of that adhesion, if you will. And that's what will eventually, the more cycles of those hot knives you have where it cools, heats up and cools, then those 2 sticks of butter are not going to be 2 sticks. They'll be one. There'll be one fused stick. And that's essentially what a fused joint is. Not commonly seen in rheumatoid, but other types. Anky means fusing. So ankylosing means fusing something. And that fusion can be in the spine or other areas, but that fusion is a result of multiple cycles of inflammation that has led the bones to basically melt. It's more dramatic. It sounds more than it is, but it's very long term. When you fuse something that's osteoarthritis, which is done for it, but that's a therapeutic fusion. Therapeutic meaning it's a treatment, because when you think of function, when you have intractable pain and loss of function, sometimes, like for example, if this finger was hurting me to the point that I can't sleep, I can't do anything, I can't literally function, then sometimes it's better just to fuse it to reduce that pain. Yes, you'll lose that level of mobility, but you'll gain that quality of life. So sometimes fusing a joint is better than having to deal with all of that complicated things. So, and that's commonly done for the back when you have nerves that are very pinched. It's hard. You don't really have a, you can't regrow a spine. We tried regrowing joints. It doesn't really work with stem cells. You can replace joints, sure, but for things like the back, when you have such a narrow area, the next best thing is just to fuse it together so it doesn't irritate the pinching of the nerves and numbness and weakness. So it helpful, but it's different from the inflammatory fusion than that one. I hope that answered the question, because there's many different ways you can approach that.
Yeah, no, that's great. Is stem cell research an area that rheumatology takes advantage of regarding treatment options?
Did I hear stem cell?
Yeah.
That's great. And I think there's more in the line of there's a lot of course, lupus, I think is probably the classic one that comes to mind. There are like CAR T therapy, there's immunotherapy for sure. And stem cells, there's a lot of pilot studies that have come out that revolutionized patients with refractory disease, got therapy, and now they have no disease because the cells that were doing all the damage are now replaced. So we generally, in routine clinical practice, currently know, but that's one of the frontiers that I'm sure we will evolve from treatment to cure at some point. So as of now, it's mostly research-based, but I'm sure it's going to be more devolving into the clinical role in the next several decades.
Okay. Last question, and I'm going to generalize this a little bit. Can unusual, at birth, unusually large digits, bone malformations contribute to arthritis later in life? And I think in this case, I'm probably meaning osteoarthritis rather than rheumatoid arthritis.
I think it's really broad, because when you think of at birth, when someone says large, I'm assuming it's pathologically large, not just like relative
Right.
to variations in population. And things that happen at birth are usually like genetic. And when you think of autoinflammatory diseases, they're different from autoimmune diseases. So autoinflammatory stuff you're born with, immune is what you learn and adapt to over time. Genetic diseases are metabolic inherently in nature. So things like rickets or vitamin D deficiency, calcium deficiencies, cancers of early childhood, and even things like chondromalacia, things that are increased bone growth. We have yes, you do. Even adrenal insufficiency and excess. They generally, a lot of them have earlier, not to say that you are 100%, but the way that we usually explain it is that it may happen earlier than someone would have had otherwise. So it's not to say that, if you would have had it, for example, if you're going to get it at the age of 80, you would now maybe, for example, 50 or 40, but the degree of it is variable. And I think joint pain is a very common consequence of a lot of non-inflammatory etiologies. And having, for example, both legs you can say that is common. For example, females have large carrying angles where their legs are generally more so angled than average, which makes the osteoarthritis in the middle half of the knee or the one half of the knee more common than the other. So the joint deformities, as a whole, yes, because the joints are not designed to accommodate that stress, and therefore will lead to more osteoarthritis in the area that has to compensate for the other half not being involved. So the short answer is technically yes, but it is so variable depending on what disease and what area and what anatomic positioning. I hope that was helpful.
Great. Okay. Well, thank you, Dr. Verma and Dr. Runyon. We appreciate you presenting this evening, and of course, always to Dr. Salam for providing the bridge and the moderation and the introductions. Next week, we're going to be hearing about the curious case of a toothy ovary. If that doesn't get your curiosity going, I don't know what will. Have a great week, and we will see you next Wednesday night. Good evening.